Hello friends, welcome to Pharma Toppers. Myself Piyush Agarwal, and today I am going to deliver a lecture on general anesthetics. So the flow of content will be like this: introduction, stages, factor, drugs. So starting with the characteristics of the drug, which is important for the anesthetics, is the induction and the recovery must be very rapid, thus allowing the level of anesthesia to be adjusted during the course of surgical operations. Because of this reason, inhalation anesthetics were the first to be discovered for the most surgical procedures. Nitric oxide was found to be caused euphoric, and analgesia and loss of consciousness, thus used as a laughing gas. So MSC, which is represent the minimum alveolar concentrations. Anesthetic potency in the human is usually expressed in MSC, which is required to abolish the response to surgical incisions in 50% of the subjects. So the correlation between MSC is found to be inversely proportional to the potency and the lipid solubility, which is expressed as oil is to water partition patients for a wide range of inhalation anesthetics. So according to Wharton-Meyer theory, which was based on the oil is to water partition coefficient, or in other words the lipid solubility, was assumed to be predict the partition into the membrane lipid, thus consistent with the suggestion that the anesthesia results from an alteration of the membrane function. So another theory which came into force is the simple introductions of the inert foreign molecules in the lipid layer might cause the functional disturbances, which is not explained by the lipid theory of Wharton-Meyer. The two possible mechanisms could be the volume expansion or the increase in membrane fluidity, which have been suggested but is largely discredited. And again, the protein came into action, where the correlation of the potency is determined with the lipid solubility being explained by the effect depending on the concentration of the anesthetics, and it is supposed to be that the protein is a target in the hydrophobic region of the neuronal cell membranes. Now the potassium channel of which is involved is TREC, which is a 2-port domain with the 4 helix and the 2 P loops, shows the outward rectifications and the strong repolarizations, thus contribute to the resting potassium conductance. And it is found to be anesthetic sensitive channel, where it is activated and thus reducing the membrane excitability by the low concentrations of the volatile anesthetics. So general anesthetics at a concentration has been found to inhibit the function of excitatory channels like glutamate receptors, and also facilitate the inhibitory channels like GABA A receptor and glycine and certain potassium channels, and these interactions are targeted at the specific hydrophobic domains of the channel proteins. So as the concentration of anesthetic is increased, the brain functions are affected, mainly the motor control, reflex activity, respirations, and the autonomic regulations. So at cellular level, it was found that the effect of anesthetics is mainly to inhibit the synaptic transmissions. So inhibition of this transmission caused the reduction in the transmitter release and action of the transmitter, as well as the reduction in the excitability of the postsynaptic cells and reducing the postsynaptic response, which is considered to be the main factor. So reducing the acetylcholine release occur at the peripheral synapse, and thus reducing the sensitivity at the excitatory transmitters due to the inhibition of the ligand-gated ion channel or the inotropic channel, thus occur at the peripheral and the central synapses. So anesthetics, like other depressants of the CNS, are potentially addictive. The anesthetic stage comprises of the three main components, that is unconsciousness, loss of reflexes or muscle relaxation, and analgesia. At even low concentration, it was also found to produce the short-term amnesia, and high concentration leads to the CNS shutdown. In the absence of artificial respiration, a death may could occur due to the respiratory failure. So the most sensitive region appears to be the midbrain reticular formation and the thalamic sensory relay nuclei, in the inhibition of which results in the unconsciousness and analgesia respectively, whereas the anesthetic causes the inhibition in the spinal level, produces the loss of reflexes response to the painful stimuli, But in practice, it was found that the neuromuscular blocking agents are used to produce the muscle relaxations rather than relying on the anesthetic tone. So now coming to the next slides. Here you could see, friends, the chart of characteristics for the ideal anesthetics, which is important to be remembered. Like it must be adequate for the relaxation of the skeletal muscle, where the point to be considered is the concentration, the potency, the margin of safety, and the chemically compatible with the anesthetic devices, inexpensive, non-reactive, pleasant induction and withdrawal of the anesthesia. So here are the stages of anesthesia, that is stage 1, 2, 3, 4, which is characterized by analgesia, delirium, surgical anesthesia and respiratory paralysis respectively. So it starts with awake and ends with the surgery and thus withdrawal, and the symptoms of each stage, which is important to be remembered. So coming to next slide, all the anesthetics decrease the cardiac contractility. Nitric oxide increases the sympathetic discharges and plasma noradrenaline concentrations, and if it is found to use alone, it increases the heart rate and blood pressure. So halothane was found to be the opposite effect of nitrous oxide. So many anesthetics like halothane has a relaxant effect on the uterus, and thus it is limited to the use of obstetric purposes, and it also found to cause the ventricular extrasystoles. The mechanism which involved is the sensitization to the adrenaline with no harm causing to the patients. If given to the patients with the pheococytoma, that is characterized by the hypertension due to the increase in the secretion of adrenaline because of the tumor in adrenal gland, there is a risk in the precipitations of the ventricular fibrillations. So halothane sensitizes the heart to adrenaline, thus predisposing to the cardiac arrhythmia. So the metabolism of halothane yields trifluoroacetic acid, which is important, which reacts covalently with the protein, especially in the liver cells, and thus the fluoroacetylated derivatives of the liver proteins are believed to initiate the immune response. Again, coming to the nitrous oxide, whose exposure greater than 6 hours cause the inactivations of the methionine synthetase enzyme, which is required for the DNA and the protein synthesis, and thus resulting in the bone marrow depressions and causing the anemia and leukopenia, and thus it must be avoided in the patients suffering from anemia due to the vitamin B12 deficiency. And again, it was found that nitrous oxide takes few minutes to act and cause a period of excitement before anesthesia is produced. Intravenously if given, it causes unconsciousness in about 20 seconds as soon as the drug reaches the brain from its site of injections. So this drug is not basically biotransformed by the enzymatic reactions in human tissue, and 99.9% of which is absorbed and eliminated unchanged. So the cause for the anemia is it can be degraded by interaction with the vitamin B12 in the intestinal bacteria, and thus it results in the inactivations of the methionine synthesis and thus producing the signs of vitamin B12 deficiency results in the megaloblastic anemia and peripheral neuropathy. For the long-term administrations of the nitric oxide thus results in the patients to be avoided. So because of these reasons, this could not be given in the chronic analgesic or as a sedative in the critical care. So again, if in pneumothorax or the vascular air emboli is present, or if intestine is obstructed, or the prolonged exposure at a very low concentrations of the nitric oxide far below the level of anesthesia is given, it might affect the protein and the DNA synthesis, and it has been suspected to cause the increased frequency of abortion and fetal abnormality among the operating theatre staff, because they are also the one to be exposed at the lower concentrations of these gases. So coming to ketamine, all the anesthetics depressed the respiratory markedly and increased the arterial partial pressure of the carbon dioxide. So nitric oxide has much less effect, mainly due to its low potency, which prevents the very deep anesthesia. So some of the inhalation anesthetics are desflurane, which are pungent and liable to cause the laryngo and bronchospasm. So it must not be used in the induction anesthesia, which is important, but used for maintaining it. The anesthetic consists of mainly three components I have already explained. so the effects of which are produced due to the combination of the drug like intravenous induction agent, that is propofol, together with the nitric oxide and the halothane. So nitric oxide is found to reduce the pain during the childbirth, and again the intravenous agent, analgesic agent, that is opioid, and thus the together with the neuromuscular blocking agent produce the muscle paralysis. So together with all these drugs, if given at a time, it produces the loss of consciousness, analgesia, and the muscle relaxations. So such a procedure causes the much faster induction and the recovery, avoiding long and hazardous periods of semi-consciousness, and thus enabling the surgery to be carried out with the impairment or little impairment in the homeostatic reflexes. So the blood concentrations should fall to the sub-anesthetic level rapidly when the administration is stopped, so that the patients recover the consciousness with a minimum delay. So a prolonged semi-comatose patient or state in which the respiratory reflexes are weak or absent is particularly hazardous. So the rate of the delivery of the drug from the lungs via inspired air and the bloodstream determine the overall kinetic behavior of the anesthetics. So the factor to be considered for the speed of inductions and the recovery are the properties of anesthetics like blood is to gas partition coefficients, which determines the solubility in the blood. The lower the blood is to gas partition coefficient, the faster is the induction and recovery. So low is the ventilation rate and the slower is the equilibrium. And the oil is to gas partition coefficients, which determines the solubility in the fat, the potential of the anesthetics, and also influence the kinetic distribution in the body, and the main effect of which is high lipid solubility delays the recovery of anesthesia. The physiological factors are alveolar ventilation rate, cardiac output. So here you could see, friends, the chart of the drugs which are used as a general anesthetics, and the point to be remembered here is about the minimum alveolar concentrations are measured in percentage V by V, and the maximum of which is found in nitrous oxide, and the minimum is in halothane. Whereas the blood is to gas partition coefficient maximum is halothane, and in case of oil is to gas, same halothane. So the main disadvantage of these are important. In case of halothane, that is malignant hypothermia and the cardiac arrhythmia. Again, in case of enflurane, the convulsions and malignant hypothermia. In case of isoflurane, it is the coronary ischemia. In case of desflurane, it is respiratory depression, basically bronchospasm. Again, in case of sevoflurane, it is renal toxicity due to the fluoride. So these are the some notes which is important, like the trifluoroacetate, which is the metabolite of halothane, and the risk of hepatotoxicity is less in case of enflurane, and the recovery of desflurane is fast compared to nitrous oxide. So cerebral blood flow is a substantial fraction of the cardiac output, and the blood-brain barrier is freely permeable to the anesthetics. So the concentration of the anesthetics in the brain is closely tracked that in the top of the arterial blood. So the lower the solubility of the anesthetic in the blood, the faster is the process of equilibration and the recovery being faster. So this is because the less drug has been absorbed by the lungs in order to achieve the given partial pressure in the blood. So thus a single lungful of the air contain the low solubility agent will bring the partial pressure of the blood closer to that of the inspired air. So coming to isoflurane, which causes the hypotension, and it is considered to be as a powerful coronary vasodilator. So this can exacerbate cardiac ischemia in the patients with coronary disease because of the coronary still phenomena. That is driving of the blood from the ischemic zone to the top of the other zone where the blood is sufficiently available. So thus creating more ischemia or the blood deficient region. Coming to halothane, body fat has a low blood flow and often is having a high anesthetic solubility. So the recovery is slow and the hangover is more. So halothane is found to have 100 times soluble in the fat than in water. So the amount present in the fat after complete equilibrium is 95% of the total body. So the more the fat soluble is the anesthetic, the fatter the patient's, the more is pronounced slow phase and becomes the blood flow because of the decrease in the blood flow. So the chloroform is found to cause the hepatotoxicity, which is associated with the free radical formation in the liver cell, and the methoxyfluorine is about 50% is metabolized to the fluoride and oxalate, thus causing the renal toxicity. So coming to malignant hypothermia, which is the side effect of sevoflurane and halothane, is caused due to the production due to the heat production in the skeletal muscle because of the excessive release of the calcium from the sarcoplasmic reticulum, as a result of which muscular contraction, acidosis, increased metabolism, dramatic increase in the body temperature, which is proved to be fatal if it is untreated. So the triggering part is the halosthetic, anesthetics, neuromuscular blocking agents. So again, one of the most important factors is that the genetic mutation in the ryanodine receptor, which is involved in the calcium release from the sarcoplasmic reticulum. So the treatment is dantrolene, which is considered to be as a muscle relaxant drug, which blocks the calcium channel. So coming to next slide, inhalation anesthetics have been introduced and gradually superseded because of their flammable nature and because of the toxicity. This includes the chloroform, diethyl ether, vinyl ether, cyclopropane and methoxyfluorine. So the side effects is important. Midazolam, which is also used as a sedative and intravenous anesthesia. So it is used in case of the endoscopic surgery where the full anesthesia is not required. So here you could see, friends, the different drugs which are to be given intravenously, which is important. In case of thiopentol, hangover is the side effect. The unwanted effect is cardiovascular and respiratory depressions, which is same as in case of propofol. The most important side effect in case of etomidat is the adrenocortical suppression, and in case of ketamine is the psychomimetic side effects, and also raised intracranial pressure. Therefore, it is avoided in the cerebral ischemic patients. Few important notes are to be remembered, like propofol causes the pain at the injection site, and ketamine produces the good analgesia and the amnesia. So again, this chart represents the figures of the drugs, the type of the drug or the chemical like barbiturate, phenol, imidazole and cyclohexanone, their hangover comparison and the analgesic effect. Thiopentol is generally widely used as an induction agent. So this chart is important where it represents the different parameters like mean arterial pressure, the cerebral oxygen concentration, heart rate, cardiac output. These are important. RR interval. So these few parameters are important. So the combined use of the droperidol, which is used as a neuroleptic analgesia, means the analgesia which is accompanied by the quiescent stage with or without the loss of consciousness. So addition of 70% nitric oxide is involved to produce the anesthesia with the droperidol. So droperidol is the dopamine antagonist which is related to the antipsychotic drug together with the opioid analgesic, that is fentanyl, which could produce the deep sedation and analgesia, that is neuroleptic analgesia. Means the patient is unresponsive to the simple commands and the questions, but does not respond to the painful stimuli or retain any memory of the procedure. This is generally used in case of endoscopy where long-term anesthesia is not required. Again, the new drug, that is propanidine and althacin, which are being withdrawn because of the allergic reactions including the hypertension and bronchoconstrictions. So coming to thiopentol, which is considered to be as a high lipid solubility drug, which is generally exists as a free acid which is insoluble in the water. So thiopentol are given as a sodium salt, and the solution is strongly alkaline and unstable, so the drug is required to be dissolved immediately before it is used, which causes the unconsciousness within the 20 seconds and lasts for 5 to 10 minutes. So it binds to albumin in the liver. So in case of malnutrition or the liver disorder or renal disorder, it reduces the dose needed for the induction of anesthesia. accidental injections of which into the vein or artery, rather around the artery or the vein, causes the local tissue necrosis and ulcerations or severe arterial spasm that cause the gangrene or the loss of tissue. So immediate injection of the procaine, which act as a treatment, which is given through the same needle. So it is found to thiopental is found to precipitate the attack of porphyria in susceptible individuals. Now coming to ketamine, which closely resembles the both chemically and pharmacologically phenocyclidine, which is considered to be as a straight drug. So both are believed to block the activations of the excitatory amino acid receptor, that is NMDA, and ketamine is given as an IV, slowly 2 to 5 minutes, and the effect is more slowly 2 to 5 minutes compared to the thiopental, and produce the dissociative anesthesia, which is marked by the sensory loss and analgesia, as well as amnesia, paralysis of the patients, but without the loss of consciousness, which is important. So during induction and recovery, involuntary movements and peculiar sensory experiences often occurs. So blood pressure and the heart rate are increased, and thus it should not be given to the intracranial pressure or increased intracranial pressure patients, or at the patients which are risk at cerebral ischemia, as I have already explained in previous slides. So the main drawback of it is hallucinations, delirium, irrational behavior. So these effects limit the usefulness of the ketamine, but are said to be less marked in the children, and thus it is used in conjunction with the benzodiazepine to be given in the minor procedure in case of pediatrics, which is important point to be remembered. So these points are important, friends. Just remember these, that is halogenated inhalation anesthetics activates a member of the class of potassium channels, that is the 2-pore domain channels, as I have already explained, which is important in setting the resting membrane potential of the neuron in maybe molecular locus through which these agents can hyperpolarize the neuron. A second target of which is the neurotransmitter release. In Caenorhabditis elegans, the actions of the inhalation anesthetics require a protein complex, that is syntaxin, SNAP25 or synaptobravin, which is important point to be remembered, which is involved in the synaptic transmitter release. So the molecular interactions may explain in part the capacity of the inhalation anesthetics to cause the presynaptic inhibition in the hippocampus lobe, and thus contribute to the amnesic effect in the inhalation anesthetics by the inhalation anesthetics. So barbiturate, propofol, halothane, ketamine produces the increase in the cerebral blood flow. Etominet reduces the cerebral metabolic rate as a measure by cerebral oxygen consumption, or CMRO2, in a dose dependent manner, and also reduces the intracranial and intraocular pressure, and also reduces the cerebral blood flow, so contraindicated in case of cerebral ischemia patients. Ketamine induces the cataleptic effect, which is accompanied by the nystagmus with pupillary dilation, salivation, lacrimations, spontaneous limb movement with the increase in the overall muscle tone. And isoflurane and fluorine halothane found to reduce the renal blood flow and GFR, or glomerular filtration rate, resulting in the small volume of the concentrated urine. So the rapid uptake of the nitrous oxide from the alveolar gas serves to concentrate co-administered halogenated anesthetics. Thus this produces the second gas effect, where the speed induction of anesthesia is considered. So on discontinuation of this gas, the nitrous oxide can diffuse from blood to the alveoli, diluting oxygen in the lung, diffusional hypoxia. So to avoid this, 100% O2 is given rather than the air when nitrous oxide is discontinued. So the point here is the second gas effect is mainly produced by the nitrous oxide and halogenated anesthetics after administration. So clonidine, which is an alpha-2 agonist, found to be anesthetic adjunct for its sedative and analgesic effect, and dexmedetomidine reduces the minimum alveolar concentrations of the inhalation anesthetic by the 90%, and thus producing the anesthetic sparing effect. The antagonists of which are atipamezole, neurosteroids like alprazolam as a parenteral anesthetics, but causes the anaphylactic reactions due to the Kramer 4EL formulations, and thus is withdrawal. So other steroids are pregnenolone. So other drugs which are involved is depolarizing agents like succinylcholine and non-depolarizing muscle relaxant like pancuronium often are administered during the induction of anesthesia to relax the muscle of the jaw, neck, airway, thus facilitated in the laryngoscopy and endotracheal intubation. So the action of this non-depolarizing muscle relaxant agent is usually antagonized once muscle paralysis is no longer desired by acetylcholinesterase inhibitor like neostigmine interferonium, combined with a muscarinic receptor antagonist that is glycopyrrolate and the atropine to offset the muscarinic activations results from the esterase inhibition. So here you could see, friends, just a comparison between the enflurane, halothane and the isoflurane on the basis of their properties. So these are to be remembered. The main point to be remembered here is the seizure activity, the blood flows, muscle relaxations, respiratory depressions, blood solubility and induction of arrhythmias, and its toxicity. So these are some factors, just a synopsis of the factor like increased MSE, what are the effects on this, decreased MSE, what are the effects and what are the drugs causing this, and no effect of MSE and what are these effects. So these are important to be remembered. These are my references, and thank you for listening to the lectures. For more videos and materials or any queries, feel free to subscribe us at www.formatoppers.com.